Welcome, everyone, and always good to have you here. Today, we have a slight shift in our programming of More Tomorrows Learn, Inspire, and Value for Liver Health series. It's an introduction of something called Live Breakthrough. So, every now and then, like this time, we have a new research study or something that came out, and we thought we would slot it in with the Live series programming. As many of you know, this program is supported with a grant from Madrigal Pharmaceuticals, and we are appreciative of their support for this particular series. Next slide, please. As always, our disclosure and disclaimer statement, whatever's discussed here is for information purposes. It's not prescriptive or recommended for your own personal management of your condition. Please use this information to consult with your care team and your hepatologist or primary care physician in order to decide your customized management. Next slide, please. Okay, so very often we refer to the slide of the perfect storm of the looming public health threat that steatotic liver disease is. And with inaction, we actually can incur high costs for advanced disease management. There haven't been new medications, but we do have new medications now for the management of steatotic liver disease. I think important, particularly for this webinar, is the understanding that this organ disease is part of a multi-system disease, and that our approach should always be a biopsychosocial approach to understanding this disease and the response that we have in terms of a comprehensive care package. Next slide, please. So the storm often talked about the doom and gloom, but we think it's a storm no more, and particularly because we've had multidisciplinary teams that have been coming in the response to steatotic liver disease. We have resmetirom and semaglutide that's been approved for use. We're getting better comorbidity management, non-invasive tests, and the new nomenclature has certainly expanded the scope of steatotic liver disease, as well as heightening awareness of it. We understand the focus of lifestyle behavior change through the inclusion of alcohol use disorder. And that has sort of given us a much more comprehensive approach to it. We have a better organized patient community, but we do have ongoing risks. Next slide, please. And this is the tip of the iceberg. It's the undiagnosed conditions of metabolic associated steatotic liver disease and MASH. And we certainly need to get to better screening, etc. With today's webinar, next slide, please, Tiffany. We're delighted to have Dr. Channa Jayasekera with us. And before I go into the welcome of it, um, when we talk about the undiagnosed cases, we want to get to them early. But I think there's many lessons that we can learn from advanced disease and what we learn when people have advanced disease, its manifestation, the consequences of it, to look back of the trajectory that brought them to that condition and find where we can intervene. So that's the importance of it. So we want to do prevention, but it's in understanding treatment that we can reinforce our prevention interventions as well as improve on how we manage the disease. So with that, it's my pleasure to welcome Dr. Jayasekera, who's a transplant hepatologist and researcher at the Mayo Clinic. His work focuses on liver transplantation, alcohol-associated liver disease, and innovative models of care that improve outcomes for patients with complex medical and behavioral health needs. He was or is the lead investigator behind the PACT protocol, which is preventing alcohol-related complications after transplantation. And it's a multidisciplinary approach that integrates addiction medicine, pharmacotherapy, behavioral support, and structured monitoring into post-transplant care. So we'll go into the recent study that came out, but this has been almost the shining star for us, this multidisciplinary team approach to managing this condition. And I think seeing it in the evidence and the real lived clinical trial experience of it is phenomenal for us. So, Dr. Jayasekera, welcome and great to have you here.
Thank you so much for having me. This is exciting.
Excellent. So we always, being the touchy-feely patient community that we are, we always do a check-in. How are you and how are you feeling?
I'm doing great. I mean, I think um, the uh, the study that we're going to be talking about has led to quite a lot of interest, and it gives me a lot of pleasure to educate patients and other providers about these interventions. And so, yes, doing great.
Excellent. So the headline result of 0% heavy alcohol relapse is remarkable. So what were your clinical observations or your understanding of the unmet needs that led you and your team to develop this PACT protocol in the first place?
Yeah. In the field of liver transplantation, we encounter patients who are in dire need of some kind of curative treatment of a very difficult disease. And in the past, the patient population who had liver disease due to alcohol use were kind of underserved because there were very strict requirements of them to have periods of sobriety before they could be considered for liver transplantation. And a number of patients didn't make it. And eventually, the field, through some large studies that were done, moved away from those strict requirements to offering liver transplantation as a life saving intervention in patients who were too sick to wait. But what we observed in that population was that alcohol relapse still occurred at a fairly significant rate, uh, upwards of 25% or so. And that is a problem, obviously, because that reflects the fact that we were uh, uh, not really treating the underlying disorder of alcohol use disorder. And so the the unmet need here was to try and do something proactively before that relapse occurs. The field had been generally good about reactive interventions, such as engaging patients in therapies, both behavioral and pharmacologic, after relapse. But to our knowledge, there was no intervention that was proactive to prevent that relapse after transplant.
And that's very interesting because we often talk about Western medicine or modern medicine being a band-aid on a gaping wound. And this is a
Mhm.
big band-aid, with transplantation. But going back to the cause of it and addressing that in a proactive way, that's remarkable. And it's a shift from how we manage things. Um, uh, did you have any specific patient experience that moved you in that sort of way?
Yes, in fact, this is your research interests are so strongly related to your patient experiences. It is when you see things um, that really bring you down in clinical medicine. Transplantation is a remarkable field because it is so transformative in patients' lives, and it really gives me so much joy to practice in the field of transplant. But then there are those instances where we feel that perhaps something else could have been done to prevent this. And so that's where the inspiration comes from, where we transplanted very sick patients, and unfortunately, the underlying disorder of alcohol use was not adequately treated, or something led to that relapse, and then there was failure of the graft, or sometimes patients even passed away after going through such a significant surgery and such a change in their lifestyle.
And so the positioning of let's say alcohol use disorder across the spectrum is more like a chronic medical condition rather than just saying it's a behavioral risk factor with addiction. And so how is that perspective adopted in the use or design of PACT?
Yeah, Our underlying principle is not to stigmatize patients. Alcohol use disorder is a disorder, and we have to treat it as such, just like we treat some of the metabolic risk factors that lead to metabolic dysfunction associated steatotic liver disease. There are behaviors that are detrimental to organs, and we have to treat those behaviors and not stigmatize patients, and develop a therapeutic relationship with those patients to work with them to overcome them. No one wants to suffer from these diseases.
Right.
And so it is really incumbent upon us to engage with patients rather than drive a wedge.
Um, and so very often, or in the past, it used to be, well, it's your fault, you're drinking, right? And when we understand this as a chronic medical condition, then it can help sort of reduce the stigma associated with it, but it takes the blame away and it makes us more objective in how we understand and look at the condition.
Yeah.
Um, and so with that used to be the pre-transplant sobriety requirements. Now
Mm.
that we have PACT in place, how does it challenge that or complement that? And how do we think about it not just after, but also before?
Yeah. The pre-transplant sobriety requirements were very onerous initially. Sometimes patients had to wait 2 years before they could be considered for transplant. This was many decades ago. Subsequently, the field moved to mandating a 6-month period of waiting, during which they would go through treatment programs like intensive outpatient programs or other rehabilitation programs, Alcoholics Anonymous or other peer support programs, and so on. The field moved away from that, fortunately, in my opinion. The vast majority of transplant centers in the United States and in Europe now have early sobriety pathways for patients who are just too sick. And so we are much more fluid and less regimented, and also far more sensible about uh, when to pull that trigger of transplant evaluation, because 6 months, 2 years, these are all very arbitrary numbers,
Mhm.
and were really, in my opinion, quite unfair to patients. So PACT is a tool in the post-transplant setting, but it hasn't necessarily changed the field in terms of the sobriety requirement that the field was fortunately moving away from already.
So that's a good segue into PACT itself. Okay, so what makes this approach different? Because many transplant centers provide some degree of counseling and follow-up. And so
Yeah.
there were certain unique elements about PACT that sort of contributed to these outcomes.
Correct. Yeah. I think what the most unique aspect of PACT is that we initiate treatment, a pharmacologic intervention, very early on after liver transplant. Um, Most patients who are felt to be at high risk of relapse to alcohol, and there's various ways in which that is assessed before transplant. There's a very thorough psychosocial evaluation, social work evaluation, and so on for anyone who goes through a transplant. And so we know certain patients are at higher risks because of their recent alcohol use or the social milieu that they're in to relapse. And so most transplant centers would engage these patients in some kind of behavioral follow up with a addiction counselor, a psychiatrist, and so on. But the pharmacologic aspect is what is left behind. And that's the aspect that is not really, to our knowledge, had not been used anywhere else. However, in the addiction space, in the space where patients are treated for alcohol use disorder, these medications are widely used. They have been around for a long time. And they're safe. They have been shown to be quite safe in the setting of liver transplantation as well. And we felt that it's something that we can take on as hepatologists as well, not just leave it to a kind of the addiction space, that we can prescribe the medications ourselves, monitor the toxicities and tolerances of these medications, and then see how patients do as an adjunctive intervention to their post-transplant care.
Um, so I just want to remind our attendees on the call, please feel free to type in questions into the webinar chat or the Q&A box, and we can sort of put them as they come up to Dr. Channa. Um, so the point you made is very, very important because we talk about this from a biopsychosocial element, right? And we paid a lot of lip service to it. And very often what happened is um, uh, you know, different specialties had their tools. Okay.
Yeah.
What you guys did really well is you brought it all together and integrated it into a protocol rather than them operating in parallel. And that sort of draws on the multidisciplinary team. Okay. And it sounds good on paper, but practice is not easy. So what was the process by which you went through that? And what were the learnings and eureka moments that you may have had along the way?
Yeah, I mean, I think one of the fortunate things for me is in the field of transplantation, and especially where I work, we have a very, very multidisciplinary approach to liver transplantation. Liver transplant evaluations are multidisciplinary by definition. You have to have physicians and surgeons and social workers and addiction counselors, psychiatrists, financial folks, a lot of people working together to get these patients to transplant and ensure success after transplant. So we just leveraged those interdisciplinary connections that we have. We created a core group, a core working group, who are my co-authors on the study. And you'll see there's surgeons and hepatologists and psychiatrists and counselors and pharmacists in that authorship. And we sat down and brainstormed how we are going to approach this issue in a very interdisciplinary way. And so we came up with an internal protocol. We put that in place in December 2023, and we just tracked those patients. We had frequent follow-ups with those patients. We ensured that the medications were being taken. And if they were not being taken, we inquired as to why they were not being taken. We recorded what the intolerances were, what the pain points were. It was all kind of a learning exercise as to how
Mm.
to integrate something completely new into the post-transplant phase for these patients. And I'm happy to say the protocol still continues. So we hope to publish an even larger patient sample in the upcoming months with our experiences.
Um, so as a patient advocate, our one of our mantras is that the patient voice needs to be at the table all the time. And we are actually with Sober Livers and Jen's on the call as well. We are in the process of preparing for an ELPFDD, the externally led patient-focused drug development convening that we will be hosting with the FDA, and that's scheduled for next year. So we are in the intensive preparation phase, but it's bringing the patient voice and perspective to drug development. And I think it's synonymous or similar to protocol development.
Yeah.
And you did talk about speaking to patients and drawing on your experiences with engagement of patients. Do you think there's a role of the patient, not a specific patient who you're managing, but the patient voice more broadly in the multidisciplinary team?
100%. I mean, I think we are we have to be extremely cognizant of the patient perspective, what the patient is going through, or you're just going to fail. You have to understand, you have to bring yourself to that patient's situation and really understand what can we do to ensure success. The medical and surgical aspect is all housed within our buildings, but what happens outside is something that we have to understand better. So with this protocol and many of the protocols that we have in place, our social work teams are critically important to understand what kind of milieu is around, who are the people around these transplant recipients to support them through this journey, and what can we do to help them. So the patient voice is critical. Yes.
Um, that's wonderful news for us, and as a patient community, we look forward to engaging as best we can. I think if you had to have an ask of and from the patient community in this process, what might that be?
I think in transplant or in hepatology in general, we are fortunate that we have very vocal patient groups. And there's, in certain diseases, I also work in biliary tract diseases, and there's a group called the PSC, Patients in Search of a Cure group, which is very influential. They bring in thought leaders to their meetings. They have an annual meeting, and learn about the research pipeline and engage patients in clinical trials and so on. So I think the patient advocacy groups are critically important. I think their participation in our annual meetings, for instance, the professional meetings, is very important. So we value that engagement that patients have, and I'm happy to say that at our patient um, at our center, we have a patient support group that we have ongoing for many years now, and we have an annual uh, meeting. It's kind of like a family reunion where we bring all these transplant recipients and we have a dinner for them. There are some speeches, and we get to mingle with them and see how they're doing. It's just outside a clinical setting, and that's just such a rewarding thing. And many of these patients will talk to you about the journey that they went through and the journey that they are going through now, and the changes that they've made, and the passion they bring to uh, kind of broadcasting the life-saving nature of transplant.
And that's treating the patient as a whole person, right? And not
Yeah,
just as an individual, but as part of a community
yeah.
of people who have journeyed together, of relatives and family, and all of that. That's wonderful to hear. I want to get to a point about the medication, and I think it relates to one of the questions that has come in on the chat. So the protocol includes the anti-craving medications or the pharmacological interventions for alcohol use disorder. Was there a retooling or reskilling on the post-transplant use of this? Is this new or has it been used before?
Yes, it did require some retooling. This is not a typical set of agents that we have in our typical post-transplant medicine box, so to speak. So we learned from the literature about the use of these medications, and we discussed it as a group, and we looked at the toxicities, the tolerances. We had our pharmacists really do a deep dive into all of these different agents, because in the post-transplant setting, there's lots of different medications that patients are on, and there's lots of drug
Mhm.
interactions, there's lots of side effects that you have to be cognizant about. So this is why we had a set of 4 different agents depending on that patient's individual clinical situation. And if they were intolerant to one, we could switch to another, and so on. So this was the principle behind that, and we had to all learn how to use these medications and pay attention to side effects. In the study, I was very proud of the fact that we really paid attention to the patients who discontinued the medication. We have to learn from that. We have to learn from the reasons why patients decided not to take the medications after some time, whether it was side effects, whether it was a sense that they didn't need it, and so on. So this is a preliminary study that is encouraging, and we learned a lot about how to refine our approach in the post-transplant setting on using these medications.
And so often in medicine, we talk about, oh my God, we need new tools. Let's embark on research and development programs. But this was an assessment of the tools we have,
Yeah.
looking at the evidence behind it and reconfiguring it or assembling it with different combinations and applying it in that way for this protocol, right?
That's correct. Yeah. Sometimes the best interventions are hiding in plain sight. So you don't need to do the most advanced thing straight off the bat, because these things are right in front of us. It just
Absolutely.
takes some effort to pay attention and just kind of think outside the box a little bit, and maybe look outside your field a little bit to learn.
So on to that point, the question that came in was that this is administered post-transplant. And is there any reason why this protocol can't be applied pre-transplant or even before people get to a need for transplantation?
Yeah. These medications can be used pre-transplant as well. Unfortunately, the group of patients that we studied were the ones who were really, really sick. They were so in dire need of a life-saving liver transplant that there was really not much time to salvage them from a medical standpoint, short of a transplant. So yes, we could have used them, and many of these medications can be used in that setting. There are some limitations, of course, given how sick those patients are, but it it wouldn't have bought us much time. These patients needed to go through a transplant in order to survive. And so we then said, because we had inadequate time to treat their um, alcohol use disorder pre-transplant, we have to shift that to the immediate post-transplant setting when they're actually doing much better clinically.
So for those specific patients, but for other patients who have alcohol use disorder, uh, especially looking at relapse rate, could it be applied to other patients who are not as far on the continuum? And it is interesting because the transplant could be a precipitating event that shifts something as well, right?
Yes, that's right. And these medications are used, and this is where we learned about these medications. These are used in the non-transplant population fairly routinely. Many of them are have specific FDA indications. Some of them are used on label. Some of them are used off label for the treatment of alcohol craving in the pre-transplant setting to prevent the issue. And um, I'm not aware of any large studies of relapse rates, but there are studies of it.
Okay, so coming to the study, it was a small cohort, right? 21 patients. And
Yeah,
we also looked at a 1 year time horizon.
correct.
So, and I also want to draw on the fact that this was one of our beacons of medical practice and research at the Mayo Clinic, right? A well-resourced environment.
Yeah.
So, how do we make these results more generalizable? What are the implications for understanding scale and also applying this protocol in environments that are not as well resourced or have as good an infrastructure as the Mayo Clinic?
Yeah, I mean, I think the most elegant interventions are the simplest ones, and I think that this intervention utilizes medications that are generic, that are widely available, that require very minimal additional monitoring besides what we typically do in a post-transplant setting. You have to be cognizant of their side effects and so on. But it really was not a huge onerous uh, requirement to implement this protocol and monitor these patients. And so I think it is a simple intervention that most centers can adopt and refine. Perhaps we have to, as a field, we have to learn from these early experiences on what to do better and how to perfect these interventions. But as it is fairly simple.
Um, okay, so that's good to know. And is there some sort of assistance for centers that want to adopt the PACT protocol?
Well, yes, I think the point of publishing this protocol in great detail was to essentially put it out there and
Get the
have
word
other
out.
centers consider it for their own programs. Each center has to decide what is right for them. But what we demonstrated was that acamprosate and other agents used early on after transplant is safe and generally well tolerated and led to a low rate of relapse compared to our historical cohort. And yes, there's additional monitoring and involvement of our social workers and addiction psychologists and so on. Um, and I think it's a fairly easy intervention for most transplant centers to implement.
And might there be a remote or virtual monitoring management of this sort of protocol, given that there aren't centers everywhere, a comprehensive multidisciplinary team, but is there a remote application of it?
I think that is a perfect intervention. This is, there are already groups doing remote assistance programs for patients with substance use disorders, and I think this would be a very easy intervention for them to adopt and kind of tack on to their interventions already.
Excellent. The hepatologist, given that these would be post-transplant patients, the hepatologist would sort of be the quarterback in that multidisciplinary team, right?
In our setting, we decided to be the quarterback, but it doesn't have to be us. It can be any other prescribing provider. So I think as long as there is a interdisciplinary group where different perspectives, different sets of expertise are considered, anyone who is able to prescribe these medications could prescribe these medications and monitor those medications.
Um, okay, that's great. I have one question on immunosuppression and stem cell research, and if there's a potential for that no longer to be necessary with post-transplant patients, because that also has a risk profile associated with it.
Yeah.
So is that research looking promising from UCLA? Before you answer that, Jen, Tiffany, can we put Jen on unmute her so she can ask her questions as well? Okay,
Oh,
go for that on the
there we go.
immunosuppression.
On the immunosuppression, yes. This is a holy grail of liver transplant. We would love to not have patients on these medications lifelong, which is the current status quo. Now, all hepatologists have experienced those patients who have uh, minimized and sometimes even stopped the immunosuppression. We don't recommend it routinely. But there are studies ongoing on a very cautious approach to.
Uh, Tiffany, have
Yeah,
things frozen? Oh, there we go. There we go.
yeah. Sorry,
Uh,
I don't
yeah,
know where I got lost, but I was saying
cautious approach.
we are very cognizant of the fact that these medications have their side effects, and we would love to take patients off them, but the science is a little early right now.
Okay. Um, okay, so and nothing should be done without the supervision or consultation with the care team.
Yes, please don't stop the immunosuppression.
Jen, over to you.
Hi there, Dr. Let me see if I pronounce this right. Jayasekera?
Perfect. Yes.
Okay. Okay, thank you. Oh, so I really appreciate hearing about the dinners that you're having with the patients. I think that that is fabulous. I think that co-mingling and that patient provider environment is so helpful for doctors to learn about what the patient's real experience is in a more relaxed setting, as you put it. I think that is a fabulous way of learning from the patient voice. So thank you for that. And then you mentioned that the patients were encouraged to attend AA or other support groups, but it wasn't necessarily very structured in that setting, in that multidisciplinary approach to post-transplant alcohol use disorder. And I was curious, how do you see the role of peer support and patient-led communities fitting into a model like?
It is such a critical aspect of it. I think historically, this was the main, if you look at it as a chair, it was one of the main legs that held up that chair
Yeah.
post-transplant. We essentially, pre-transplant, we have extensive counseling sessions with patients on the need for um, peer support. Peer support is a critical and long-term intervention for many patients who struggle with these conditions. And we have not we are not trying to detract from that at all. In fact, that is a
Oh,
core.
no. Yes.
Yeah.
Yeah.
And we are not believers that pills can solve everything, but pills can certainly facilitate and may be beneficial, which was the whole intent of the study. But the other aspects have to be prioritized as well.
Yeah, they're very underutilized. I agree. The pharmacological treatments, and I'm very encouraged by what you guys are doing. One last question on the patient voice. I know that Niraj had brought that into the question as well. Have you guys considered, or do you guys have on staff like a peer support specialist as well that your patients can see?
Yeah, our center has its own peer support group, and we offer that to our patients. But frequently, patients may prefer to find a peer support group closer to home. For instance, we have patients from all over the country, but we do have a virtual as well as an in-person peer support group.
Very good, very good. Well, and you can always tell people about sober livers. We're here to help people. We have a
Yes,
lot of people post-transplant that and younger patients too that are in real need of that support. And I think having all those legs, right? Having that three-legged stool is really important, or even four-legged stool is even better, right?
correct. Exactly. Thank you, Jen. That's
Thank you so much.
exactly
I appreciate that. Thank you so much for being here. I appreciate this, especially on such a quick notice. This is
right.
so awesome.
My pleasure.
Thank
Thank you
you.
for facilitating.
Excellent. So I want to look a bit further down the road now. Okay, so where to from here? We have a 1 year timeline for the study outcomes, and certainly you have many more thoughts on and research questions as you look forward. So
Yeah.
can you give us sort of some of your views on that?
Yeah, as I mentioned earlier, we have our patient cohort still followed. These patients were recommended to be on these medications for a year, and we follow them beyond that, off of the pharmacologic therapy, and we see what happened. And we hope to publish that group. We have a larger group that is now being studied as well. We're looking at the data during that first year. And then we have to be cognizant about the drug intolerances. As I mentioned earlier, there's some side effects to these medications, and we have to make sure that we dose them accordingly. Some of the medications had 3 times a day dosing, which is difficult to do. So we have now attempted twice a day dosing for some medications. There are certain side effects like decreased appetite with some medication. So those are not. My camera seemed to have gone off. I don't know if you can see me. But yeah, those are not. Those are things that we're paying more attention to, and we will have more data on that in the future.
Okay. Um, uh, so would those medications then be chronic, or is there also an attempt to wean people off or to take a little drug holiday and see how they coping on their own?
Yeah, our intent was to just treat during the first year, and if patients are tolerating them well, and they, it will be a discussion with the patient as to whether they feel it would be beneficial for them to continue it beyond that 1 year. But we hope that in that 1 year, if there is cessation of alcohol use, there's adequate behavioral support, the patient has been able to engage with peer support, and kind of the social setting is favorable, perhaps they won't need long-term medications. It is always our intent to minimize the burden on patients. They've already been through a lot. So
Mm.
if we can avoid medication, that would be great.
Okay. So there might also be a weaning of protocol that
Yes,
goes with it, or a monitoring protocol.
correct. Exactly. That's exactly what we're doing. We're treating for the first year, and then we stop the medication at that point.
Okay. So that's looking at sort of longitudinal or depth with the study. Are you looking at breadth to look at saying, well, this is a cohort of 21, but let's go for a bigger cohort, multi-center, etc.?
Yeah. Right now we are not multi-center, but I think that may happen in the future. But we have a larger cohort. We have been this protocol has been ongoing for 2.5 years now, and so we have a larger group of patients that we are analyzing now.
Okay. How many patients are involved?
We have close to 50 now. So that's pretty encouraging that this has become kind of a mainstream protocol in our center now.
And within our patient community and in our patient networks, if we have patients who are shortly post-transplant, can they sort of, how do they talk to their centers about this? Is there an opportunity for them to get involved in trials?
I think so. I mean, I think the beauty of publication is that it is now out there. It is accessible to patients, and I think any patient who is interested in this particular intervention post-transplant can just talk to their provider and say, "Did you see that study that came out of Mayo Clinic, Arizona, and what do you think?" And I think it's a decision that has to be made with their provider, their treating provider. But I think we have tried to be as transparent as possible about the successes as well as the challenges we faced with this protocol. So
So those two messages are something that our patient community, but certainly we also share information with the provider community, our multidisciplinary psychologists and dietitians, behavior change specialists, and even hepatologists. So, what would be that sort of biggest opportunity that you would say that people can take as a message, and what would be the challenges with the adoption of this protocol?
I think the opportunity is that we are utilizing agents that are widely accessible, that are affordable, that are generally well tolerated, uh, to serve as a adjunctive intervention to a very challenging situation. Um, we are all kind of concerned, including the patients after transplant, as to how things are going to go, because it's a very touch and go year. There's a lot of moving parts in that first year, and so if we can alleviate some of that concern by initiating a fairly simple protocol like this, that could be a beneficial thing. Challenges wise, certainly, I think drug intolerances, and there was a point at which one of the medications was not available in the country. There was a shortage, and things like that can happen. But I think in general, it's not a very challenging intervention to put in place.
Um, there was a, or there is a philanthropist in health and development who was asked a question about climate change. And it was really telling. He said, well, if they had a pill for that, I would put money behind it. Right. And so often we think about, oh, let's just find the silver bullet or the magic pill cure. And that is a risk that we face. Oh, there's medication for it. Let's just take that. But the work that needs to go into it, the behavior change, the lifestyle, and the support is all equally important.
Yeah,
Even though we talk about resmetirom and semaglutide now for steatotic liver disease, we always championing those lifestyle interventions that go with it.
exactly. No, I think we are exactly on the same page, and this is kind of goes back to what Jen mentioned earlier. That there is no silver bullet. These are complex conditions that require multidisciplinary approaches, and sometimes a pharmacologic approach is beneficial, but it is by no means the only thing that will help the situation.
Absolutely, absolutely. We have one more question. I think we may have time for one or two more. So, since PEth testing is no longer widely used for transplant considerations, sounds like PACT is necessary to fill the void whereby more transplanted patients may be challenged with their sobriety.
Well, PET testing is used still fairly widely, because I think we need to detect in the post-transplant setting. We need to detect relapses early so that we can try and help patients. Relapses happen not because of some personal failing of that patient, but it's because of the condition that they're dealing with. And so we do use PET tests, and when a PET test is detected, we swoop in. We try to engage with that patient and see what we can do to help kind of come back. And in fact, in our paper, we spoke about those patients who had isolated relapses, and those were detected by PET testing, where when we engaged with those patients, they said, yes, unfortunately, I was with a group of patients, and there was a group of friends, and there was drinks around, and I had a beer, and whatever it is. And so, patients will tell you these very real day-to-day scenarios that are challenging to overcome sometimes, and we engage with those patients, and so I think the danger of not looking is that sometimes you may uh, catch the situation too late, once the relapse has occurred, and months have gone by. So we do use PET testing to detect relapses early.
So it is still being used, but I do feel like there's a shift in the tone. So before it was more an adversarial kind of gotcha
Yeah.
type of tone, and this sort of addresses the issue of stigma, right?
Yes.
Uh, but it feels like with this protocol, we now trying to balance accountability with compassionate, evidence-based interventions, right?
Exactly. I mean, I think stigma doesn't help anyone. Stigma antagonizes you with your patients. Stigma will break or really impair the therapeutic relationship and trust you have with your patients and the patients with you. So we don't approach anything in the through the lens of stigma. Um, and we have to really use these tools as early detection methods, just to kind of try and help when we can and when the help would be most effective.
Um, it's something that we have to dismantle in so many areas in health, medicine, society, etc. We have another question. I noticed that in the brief report of your study, it states that LT candidates must demonstrate insight into the role of alcohol in their disease.
Yeah.
Liver transplant candidates. Can you expand on exactly what you're looking for? Just looking for an opinion on insight.
Yeah, insight is a very important assessment for us, because we need to know that the patient in front of you is aware of the fact that alcohol is what has led to this particular situation. And that self realization is something, if it's not there, we try to develop and help that patient understand that self realization. Because if you don't recognize the problem, it will recur. And then that patient's health will deteriorate, and they would have gone through a liver transplant, this huge surgery, and all of the steps you have to get through to get better from that surgery and to live a normal life. They would have done all of that uh, in vain. And so I think that insight and understanding about the role of alcohol in their current clinical situation is a critical initial um, assessment that we make, and every transplant center makes. There's various tools that our psychiatrists and addiction psychologists use to assess that. And it's not to say that they are, um, if there's no insight or if there's inadequate insight, that we kind of dismiss them. No, it is more for us to understand where do we need to meet this patient, where at what are the interventions that we can provide to develop that insight and to ensure that this process of transplant will be successful, and that donors generosity is respected. We have a very, very strong ethical obligation to our donor families. These are patients, these are families who are making a very, very difficult decision to donate their loved one's organs to save another person's life. And we take that extremely seriously. And we will do our utmost to make sure that those organs go to someone who is going to take care and cherish the memory of that donor.
As someone who's worked in with multidisciplinary teams and even across sectors, from private sector to civil society, government, etc., use of language can be quite challenging, and we often use the word insight in mental health and in other conditions. I the term is and I think that was also part of the question. The term is almost condescending in our way of, which is very paternalistic profession from us as medical people. But I think it comes to the point of dealing with addiction or dealing with any of these chronic conditions starts off with an admission or an acknowledgement of the role of things, right?
Correct. Exactly. And that's good feedback. I mean, sometimes the terminology that's used is archaic, paternalistic. In the field, we have used words like recidivism. There's so many other terms that are just common parlance in medicine, that we have to really stop and think, okay, really, is that the right way to pitch this to a patient? Because they're going through a lot. You don't want to add insult to injury to these patients who are already fully aware of how sick they are.
Absolutely. I think we have time for one more question. Eileen, Tiffany, can you unmute Eileen so she can ask her question?
Hi, was my hand still up?
Yeah, yeah.
Okay. Actually, it was just more of a comment. I didn't mean to, but I think the awareness. First of all, I appreciate you both so much for having this organization and all the help I've received from it. But yeah, the negative stigma is a big deterrent for some people, even just taking that first step because they already feel like a loser if they've come that far. So I think the support that I've received from the medical field and my close network, like this program, the AFL program and Sober Livers, has been knowledge is power, as they say. If you can get your foot in the door and just sharing the news that comes up is so appreciative. So this is more of a thank you than a question. I do have cirrhosis, but my numbers are going down, and I have not had to face the transplant issue at this point. So I'm keep plugging forward. So anything that I find out that there is hope, and I love
Yeah.
that. So and it's through organizations such as this. So keep doing what you guys are doing. It's changing lives and it means the world. So thank you. And thank you, Jen, if she's still on.
Thank you so much for that comment,
Thanks,
Eileen.
Eileen.
Yeah, that's it's so great to hear a patient's perspective, and I think we have to keep reminding ourselves in medicine, as Neeraj also mentioned. I mean, we're traditionally a very paternalistic field. You come from there's a huge kind of power differential historically in medicine, and that really has to be eliminated. And I think. Really kind of engaging with patients and meeting them where they are at is critical in this particular disease.
So we've come to the hour, and I have just a closing thank you for the time you spent with us, for the work that you are doing, and the impact that this is going to have on the patient community. And I think it would be fitting for me to read this comment from one of the participants in closing, because I think it sums it up. I'm actually choking up with it. Overcoming alcohol dependence is one of the toughest challenges for anyone. Love the compassion that Dr. J embodies. That's you. I could only face the storm through the compassion of my University of Colorado transplant team and my counselor. So I think this is a beautiful point of convergence from so many different perspectives. And it is through that sort of sense of solidarity and working together that we can achieve these outcomes. So I
100%.
thank
Thank you
you
so
so
much.
much.
This was really wonderful and so great to have this discussion, and to all the participants, really appreciate you listening in, and for those thoughtful questions and comments, and best of luck to everyone.
Thank you so much. Take
Of
good
course.
care.